Hey, my name is Chun Yuan from University of Washington. I will moderate the first session today called Clinical Applications. The first speaker is Dr. Kevin DeMarco, that his topic will be intracranial MRA. By the way, he will actually also give the talk for Dr. John Houston that follows his. So he will just continue on rolling on and on.
Yes, and I won't leave any time for anybody else, so including our moderator who's speaking afterwards. Well, welcome back from an excellent lunch break and a really great educational symposium. What we're going to do this afternoon is kind of build on some of the clinical applications, and I've decided to limit my discussion here to intracranial MR angiography. I'm a United States Department of Defense employee, and these are the required disclaimers by the U.S. government. MRA, how do we use it? Clinically, we use it every day for aneurysm screening, and I'll go over especially more advanced post-processing with volume rendering. We also use it to evaluate patients who have had aneurysms treated clinically. So the first thing is just finding the aneurysms, identifying proximal intracranial artery aneurysms. Multiple studies out there showing that we have at least a 95% sensitivity and specificity to find proximal intracranial aneurysms 3 millimeters or greater in diameter. These are the ones that could potentially grow and are the important ones to find. Importantly, it's not good enough to miss 5% of bleeding aneurysms. So if a patient presents with acute subarachnoid hemorrhage, they go straight to conventional angiography. However, it is an excellent screening modality in patients at moderate risk, such as those with a genetic predisposition, or you have a finding on MR or CT that you're wondering if there's an intracranial aneurysm. We had an excellent discussion this morning on time of flight imaging, and I'll have a few schematics to discuss in Dr. Houston's section when we get to the neck. But spin saturation is one of the problems where the flow, instead of coming in an axially oriented, is coming straight in and out of the volume. It stays in the volume for a long time. So there are well worked out multiple modalities to help us deal with this, including overlapping thin slab acquisitions, acquiring with a different flip angle the images from the bottom to the top of these thin slabs. Different manufacturers give them different names. And we can also use magnetization transfer contrast to decrease the intensity of the brain, especially at 1.5 Tesla, to make the flowing blood vessels big. But what really was exciting was to hear John Houston describe some of his initial clinical experience when Mayo Clinic installed the first clinical 3T scanner, and especially for MR angiography. It was the killer app that drove the MR manufacturers to develop 3T MR. We got the usual doubling of signal to noise at 3T compared to 1.5, but we also got a marked improvement in contrast to noise because of the prolonged T1s that we heard about this morning, decreases the signal intensity in the background brain. Pulsatility artifact, of course, is more difficult at 3T. There's a number of ways to manage this, including elliptocentric reordering. And our in-plane resolution is equivalent to that of CT. So this is one of those examples that I was mentioning. This was a 59-year-old female who presented to us. You can see here in the back of the brain all this T2 bright gliosis. She had had a herpetic encephalitis 3 years earlier, was stable from this, and this was just a routine screening brain MRI. This was the first time we had acquired it. At 3T, we got nice thin images. At 3T, all of her previous studies have been 5 millimeter thick, and I was looking going, what's that ball doing right there? Could that be an aneurysm? So we brought her back for an MR angiogram. And indeed, on the MR angiogram, this is the anterior communicating artery, the A2 segments of the right and left anterior cerebral artery. Excellent. And right there was the inferiorly projecting aneurysm. And we saw it nicely on our MIP image. I know, especially if you don't do cerebral angiography every day, this obliquity is a bit confusing, but this is the internal carotid artery. This is the posterior communicating artery. This is the internal splitting into the anterior and middle. And this is the A1 and the A2 segment, and that's the aneurysm right there. The neurosurgeon then took the patient to conventional catheter angiography. One of the concerns or questions they had was whether this would be a good candidate for coiling versus clipping. And you see, both with the MIP imaging and the standard 2D planar imaging that we get with DSA, they both suffer from not having depth information. So we can take that same 3D data set, just post-process it a little bit smarter with volume rendering, where we get a lot of depth information and we get a lot of information at the surface of the vessel wall. And notice, this wasn't a nice smooth aneurysm as the MIP projections implied. There's these multiple outpouchings from the dome of the aneurysm, and that was confirmed with angiography. In fact, the angiographer who did this, our senior neurosurgeon, was actually bemoaning that he thought our pictures looked a little bit better. But this tells us that this aneurysm has bled multiple times in the past, although she didn't have any symptoms. So armed with that information, the decision was made to treat the aneurysm, and they decided to go ahead and do neurosurgical clipping. So again, here was the preoperative angiogram, and then here is the postoperative angiogram. This is a curved sagitta clip where they come right in underneath the neck of the aneurysm. You can see it's completely healed. And so this is a great example of one of the many roles for cerebral angiography. This patient was unknown to have an aneurysm despite multiple prior brain MRIs, and likely would have bled, and 1/3 of the people die from their acute bleed if it's not known. So we found it when she was still asymptomatic. Well, what do you do after an aneurysm has been treated? The one I just showed you right now, the aneurysm was clipped. In those, I strongly recommend you go to CT. The metal artifact on MR, even with the new MR compatible clips, can still be problematic. There's still some safety concerns at 3T. Conversely, if the aneurysm is treated endovascularly with coils, those coil masses are so dense you get very bad streak artifact on CT, and I recommend you go straight to MR angiography. We talked today about how to build a practice, and kind of knowing where each of your modalities can help you is important. The newest technique for treating aneurysms is flow diverting stents, and they're an MR or CT are fairly equivalent because you're not completely and immediately occluding the aneurysm with the flow diverting stent. You're just slowly choking it off. And what the surgeon wants to know is, does the size of the sac of that aneurysm get smaller over time? So this is a different patient. Here is the internal carotid artery, the anterior cerebral, the middle cerebral. This is the artery going to your eye, the ophthalmic artery, and you notice right near it, we call it para-ophthalmic, was a superiorly projecting para-ophthalmic aneurysm. Very difficult to clip surgically, a lot of bone in the way. So the surgeons put a flow diverting stent, and you can almost get the idea that you can see it right there. Yeah, I think that's projecting. And notice the aneurysm isn't completely gone, it's flowing very slowly. So we heard this morning about, ooh, that's a problem with 3D time of flight because we need fast flow. So indeed, if all you do is standard non-contrast 3D time of flight, you don't even get to see that aneurysm sac. So we do a couple of things in the post-op follow-up. One of them is to do a post-contrast 3D T1 because, of course, our techniques are T1 weighted. And you can nicely see the residual aneurysm sac, and we could tell that it was smaller than it was immediately post-angiography. And then the surgeon decided to go with CT the following time because he was a little bit worried for some other reasons that there might be some stenosis developing within the stent, and that's very good right now with CT. And you can see the sac has almost completely gotten smaller. So there's multiple ways that we can follow up patients after they've been treated, and we target it and tailor the study to answer the clinical question. This was an interesting patient, active duty sailor who presented down to the downtown hospital with acute subarachnoid hemorrhage. He's one of the lucky ones that survived, and he was so unstable he could not go in for surgical clipping. So what they did instead is they went ahead and put some coils in the dome of the aneurysm just to get the bleeding to stop, stabilize them. They sent us to us for follow-up. So here's the three things that I do in post-op aneurysms. I do a regular non-contrast time of flight, We do the first pass contrast MRA, exact same way we do in the neck, exactly like we heard this morning. And then I do the post-contrast 3D time of flight. And the reason for that is each of them give me different information. The 3D non-contrast shows me soft tissue. I can see the coil mass. And yes, I get a little hint of some residual flow. Kind of see it a little bit better on the post-contrast, but in particular, I see it very well on the first pass contrast MRA. And so same scenario. This patient then went to angiography and neuroembolization for definitive. And you can see we've basically taken out all of the residual aneurysm. Here was this big, and the coil mass was right here. There were big portions of it still present superiorly and inferiorly. And the only thing that's left is this little nubbin, but we couldn't take that out because this was the big posterior communicating artery supplying the back of the brain and had to stay there. So how do we use intracranial MRA angiography? We use it for screening in moderate risk patients. Hopefully I've shown you where I think the volume rendering really helps. We also use it in the post-op evaluation, CT for clipping, but for coiling or endovascular, consider contrast enhanced, 3D time of flight, non-contrast, post-contrast, and first pass contrast enhanced MRA. Now I'm going to change shifts as was alluded to. John Houston sends his regards and his regrets. He was unable to attend, which is, as he and I were talking, and as I think most of the people who routinely come to this meeting, it's our favorite meeting of the year. And he was very disappointed not to be here. So he told me to tell you all hello and send his regards. For extracranial and intracranial atherosclerosis, as we heard this morning, we have some really well time-tested techniques, 2D and 3D time of flight MRA, first pass contrast MRA. I hope I'll convince you that you don't want to simply look at the MIP images, but do your measurements on the NPR. We heard the value of quantitative imaging this morning. We'll also begin to give a hint of extracranial and intracranial vessel imaging. We'll hear a lot more of that in our next session. 2D time of flight initially started and was initially presented at these meetings as an excellent screening modality. We could get good coverage from the arch through the circle of Willis, and it was very sensitive to severe greater than 70% stenosis. But it wasn't very specific. Dennis Parker and others then developed and implemented multiple overlapping thin slab acquisition, or MOTSA, which became the mainstay both for cervical and intracranial MR angiography, and it still had the high sensitivity of 2D time of flight, but much more specificity. Its downfall was that relatively limited coverage, typically in the middle of the neck. Then the next set of techniques that were developed was the first pass contrast MRA, and it kind of combined the best of both worlds. So this is my schematic, and none of that came over very well. Okay, you get the basic idea. So this is the stationary magnetized soft tissue in the neck, and this is the magnetized protons in the blood. And then what this is schematically representing is very slow flow. And we can see that even with slow flow, we can still detect flow-related enhancement because we're only imaging a very thin slice, typically 2 millimeters. So if you do the math with a TR of 50 milliseconds, this flow only has to be on the range of 4 centimeters a second, typical of venous flow. That's why this is a good technique for the brain. And that was its main purpose. And the other thing is you could stitch a number of these slices together to get you the high coverage. So that was the original technique with 2D time of flight, but it lacked the ability to measure the stenosis. With the 3D technique, especially the MOTSA variant, we were able to get much higher in-plane and through-plane resolution. Instead of 2 millimeter thick, 1 millimeter thick slices is routine. We could get higher spatial resolution. And so this schematic shows the same issues that I was just describing, but here, now, and let's assume this is the internal carotid artery, but instead of flowing very quickly through the imaging volume, it's flowing very slow. And that can happen when you have a high-grade flow-limiting stenosis in the proximal internal carotid artery, the flow distally may be so slow that you can't see it, and you will falsely think that the vessel is completely occluded. So again, doing the math, if you assume a TR of 30 milliseconds, the flow has to be 100 centimeters a second. We heard in the thoracic aorta it's quite a bit faster than that, and 100 is fairly typical in the carotids. Then your individual slabs of 30 millimeters or 3 centimeters is enough to completely replace the flow. And if you shrink your slab volume down to 2 centimeters, the flow can be a little bit slower than that. And so here from my initial experience with this when I was at the Navy Hospital in San Diego, we did digital subtraction angiography and then the MOTSA technique with an excellent correlation. And so these are the standard non-contrast techniques that are widely available in all major manufacturers. We heard a lot of exciting new technology that's coming out as well. So this was a nice comparison about what I mean. 2D time of flight, you see the flow gap, but you can't measure the stenosis. Highly sensitive, but not really very specific. The 3D time of flight does an excellent job of showing the stenosis, but because of spin dephasing distal to this high-grade stenosis, the length of the plaque looks to be quite a bit longer than it actually is. And then contrast MRA shows us that it's just a focal plaque right at the bifurcation. Helps the surgeon plan how long his incision needs to be to take that plaque out. The other thing I wanted to describe with you guys is measuring the stenosis. And again, from my initial work in San Diego, we started off, as everybody was at that time, measuring off of MIP images. But notice that the edge of this vessel, yeah, good, that's projecting well, is very ill-defined, and it's hard to measure. And so when we did multiplanar reformations, has higher contrast to noise, especially in areas of low flow related enhancement, and it was much easier to see the wall. And so what myself and another neuroradiologist did in a double-blinded fashion was measure that stenosis and compare with the DSA. And notice when we took the exact same data set, 3D time of flight MOTSA, just smarter about how we measure stenosis off of the MPR instead of the MIP. This was the first study to show that MRA actually doesn't overestimate stenosis, and that misconception still exists till today. With properly done techniques, we do not overestimate stenosis compared to the DSA. You just need to be smart about how you measure it. Next thing I'd like to go through with you is understanding elliptocentric contrast phase encoding, our single-pass contrast MRA. And we had excellent description this morning about K-space. And so, what we're doing here is we're acquiring a typical Cartesian where we're doing multiple phase encoding steps and then filling up all of our lines of K-space until we get fully sampled K-space we discussed this morning. You do the Fourier transform and you get a high resolution image. As we talked about, only the center 10% of K-space is where the information about the signal intensity at each point exists. As Chuck told us this morning, there's a 1-to-1 correlation between the K-space and our final image domain image. And the 90% of K-space is where the edge or resolution information exists. And with 3D, that gets even more complicated because we have to fill these lines of K-space in 2 dimensions and fill this whole box. So Steve Reeder introduced the idea of elliptocentric reordering. At the time, all the major manufacturers offered Centric, which started the phase encoding steps, the low phase encoding steps in the Y direction, but not in the Z direction. Steve's idea was to move everything to the center of the box, and that got us through the center of K-space much more efficiently. As Giles mentioned this morning, we were all aware of our limitations with centric imaging, that it took about 1/3 of the acquisition to cover the central part of K-space, and given that we have about 4 to 5 seconds separation between peak arterial and peak venous enhancement in the neck, that meant my study couldn't be more than 12 seconds. with elliptocentric reordering, we're now able to get through the center of case space in about 10% of the acquisition. So we can now easily extend our scan to 40 to 50 seconds. And with that extra time, we can get more phase encoding steps in the Z direction, get better coverage of the aortic arch, and we can get higher spatial resolution. Of course, with a 45-second scan, there is some opacification in the veins, but it's just the edge, and this edge effect is very easily suppressed with standard MIP imaging. What I'd like to do is to draw your attention to our society's webpage. You go on our clinical protocol section under resources, and this represents a joint article that I wrote a few years ago in Neuroimaging Clinics, which Elsevier has kindly allowed us to reproduce on our webpage. And its recommendations for 3 of the manufacturers for contrast-enhanced MRA at 1.5 and 3T. And tomorrow afternoon, we will be hosting a protocol committee meeting where we hope to get more input from all the attendees about updating these protocols. But we want to give these protocols and make them widely available. The advantages, again, is better estimation of the length of the plaque and ulcerations. Remember I mentioned you can't be sure when there's a high-grade stenosis if the internal carotid artery is patent. So is this internal carotid artery patent or not? Is this internal carotid or is it just fat? Here on the contrast MRA, you can clearly see it's still patent. The surgeon needs to operate. And horizontally oriented vessels have problems with spin saturation. That's not a problem with contrast-enhanced MRA. In my remaining few minutes, I'd like to just kind of introduce the concept of black blood imaging, vessel wall imaging. And Dr. Anwan will discuss this in more detail in his presentation. I'd like to draw your attention to one of the late vulnerable plaque features, intraplaque hemorrhage. We make use of the T1 shortening of intraplaque hemorrhage to identify it. So a T1 weighted sequence, either MP-RAGE or a 3D fast spin echo T1, can show us the high signal intensity of intraplaque hemorrhage. And we can see here that we have good quality contrast-enhanced MRA. Even though there's only a mild stenosis here, we can see the intraplaque hemorrhage. And we can recon both of these acquisitions obtained coronally into the axial plane, and we can see there's an ulceration. And yes, I know that stenosis looks tight, but when you use NASET and you measure it to the distal non-tapering, that was barely 30%, and that was being generous. We know we're worried about this plaque because there's an ulceration, and we can see we have juxtaluminal hemorrhage. This was a 65-year-old female that presented to an MSU neurologist, Michigan State neurologist, when I was there. He was very confused, wasn't sure if this was a seizure or TIA. The brain MRI didn't show anything. By the time she showed up, she didn't have symptoms. We took an unknown and made it a known for him by simply adding that 4-minute sequence. Intraplaque hemorrhage has been shown in multiple meta-analysis to be highly correlated with poor outcome, with almost an 18% risk of future cardiovascular events, stroke or TIA, cerebrovascular, compared to a little over 2% if you don't have plaque hemorrhage. So it's a very potent marker of plaque hemorrhage. And then in the last few minutes, intracranial vessel wall imaging, basically the same concepts of neck, but we need much better I'm sorry, this is for MR angiography. The same thing, we just need to do more about the flow saturation. And vessel wall imaging, same concepts, but we need much better spatial resolution. And we'll hear some more about that in a minute. Even with the techniques that we have right now in this population-based atherosclerotic research in the community study of almost 2,000 patients, they were able to identify 34% of the patients, no known cardiovascular disease at all, that had intraplaque hemorrhage. And we can, intraplaque wall thickening, as you can see here, and evidence of intracranial arterial disease. This is another patient with an acute embolic stroke and the right MCA distribution, absolutely no narrowing of the MCA, and yet you can see eccentric wall thickening and T1 hyperintensity. So this patient had a vulnerable plaque in the right middle cerebral artery without any evidence of stenosis. So intracranial vessel wall imaging can be helpful in a wide variety of diseases, not just atherosclerosis. So what I've tried to do on John Houston's behalf is go through extracranial, intracranial atherosclerosis, time of flight, contrast MRA, introduce some of the concepts of extracranial vessel wall and intracranial vessel wall imaging that we'll hear more about in the next session. Thank you very much.